Thank you, Dr. Mohanty. Thank you, Dr. Kaningo, Dr. Das, Dr. Panda. It's a pleasure being here, and my task is to uh, share some clinical perspectives on how we managed diabetes during the pandemic. I hope my slides are visible and that I am audible.
Yes, Unni, go ahead.
Yes. So my talk is titled Clinical Perspectives in Pandemic Diabetology. And I will just discuss some case studies because I know a lot of people attending this meeting are actually practicing doctors. So let's begin with a case. Now, this is a 33-year-old lady who presented with hyperglycemia during pregnancy at 25 weeks of gestation. So this was her first successful gestation after undergoing 5 cycles of IUI and IVF and 6 cycles of IVF. Her father had diabetes and she had now been diagnosed to have gestational diabetes at 25 weeks. Her blood glucose level is high. The fasting was 93 and the post-meal value was 225. In view of this being a very precious pregnancy and high blood glucose levels, the infertility specialists referred her to us for further management. But because of the lockdown, she was not able to commute to a hospital, and she approached our hospital diabetes care team via video consultation for management of sugar. So let's look at her case. So this lady was given a glucometer which synced to a mobile phone and could sync to a cloud. So our diabetes educator sitting in our hospital could actually monitor her blood glucose levels. And she was doing her self-monitored blood glucose 6 to 7 times a day. And we took out the mean of each week. And you can see that her blood glucose levels, the mean was around 87 initially before breakfast. After breakfast, it is 156, pre-lunch was 89, post-lunch 151, pre-dinner 98, and post-dinner 144. So because this was a video consultation and we wanted to be as careful as possible, we started on metformin twice a day, continued it, and eventually you can see the blood glucose levels coming down. The fasting came down to around 76, the average fasting. The mean post-breakfast came down to 126. Post-lunch remained a little high, 140 to 146, and the post-dinner came down very nicely to 123, 114. And she indeed, the monitoring reduced and she delivered a healthy baby. And we published these 3 cases where we managed gestational diabetes through telediabetology, the diabetes part, in all the 3 cases quite effectively. And many cases, lifestyle advice is enough for gestational diabetes because in gestational diabetes, the hyperglycemia is mainly postprandial and diet really helps, and metformin can also be used. Now let's look at a second case. This is another case who came during the pandemic. So this is a 50-year-old lady known to have diabetes mellitus since 6 years. She's also hypothyroid and had a spine surgery. Also had some eye surgery, probably a vitrectomy and a laser 6 to 7 years back. Took a video consultation. You can see that, again, it was during the pandemic. Her HbA1c was initially 12.4 in April 2020. And when she approached us, it was around 10%. Her fasting was 289 and 285. The kidney functions were normal. The postprandial was high. TSH was high. She was taking premixed Lispro once a day and glimepiride metformin twice a day, vildagliptin metformin, some thyroxine and multivitamin. So what we did is that we shifted this patient to a basal bolus regimen of glargine and aspart. We gave her aspart before breakfast and dinner and glargine at bedtime, and we gave her a small dose of repaglinide voglibose with lunch. We continued the vildagliptin metformin and continued the thyroxine, and she was started on CGM remotely and glucose monitoring. What you will see is that the glargine dose was carefully increased. The fasting was 180, glargine increased. Our diabetes educator increased glargine further to 273. The sugar was 273, so glargine increased to 14. Glargine was further increased to 18 and then 20. And you can see the fasting coming down very well. Remember, initially it was 280, came down to 180, 270, 200, and finally 159. And these were her continuous glucose monitoring readings, showing you that the glucose management indicator was 7.3. The daily average was 163. You can see the median showing some intraday variation, especially after lunch. Initially, you can see the time in target was almost 0% and improved towards the end. The blood glucose levels, the time in target was almost 55% acceptable. But if you see the overall time in target was only 29%, but that's the average of all these days. But you can see fairly good control was achieved towards the end. Just to show you that remote management of diabetes is possible in a compliant patient, a motivated patient, a patient who can use technology, and a patient who does regular glucose monitoring. So this is another case, a 66-year-old gentleman who presented to us for an online consultation with a toe injury. He had diabetes for 10 years. He also has neuropathy. He was taking insulin and OADs. He monitored his blood glucose levels regularly and visited a doctor for regular diabetes checkup. What we found is that during the pandemic, he sustained an injury to his left big toe, for which he self-dressed the wound 3 days with a topical antibiotic cream. On the third day, he found that the wound was oozing and there was a yellowish discharge. He consulted the physician at our hospital online. He described it. He said he couldn't visit the hospital and he shared the image of the wound. So this is the image, as you can see, initially after he cleaned it, but he noted that there was slough and pus oozing from the wound, and with dressings which we trained over video consultation with offloading, with antibiotics and rest, you can see the wound healing. So this was therefore a very simple case of a superficial infection which could be managed by telepodiatry, and we published a series of illustrative cases on telepodiatry just a few months back. This is another patient who presented with an ulcer and was debrided. As you can see, this is a typical neuropathic ulcer. You can see this patient had a big toe and great toe amputation. The first and the second toes amputated earlier, and therefore debridement was done. There was under this callus. You can see very clearly the callus which would have broken, and the pus under callus. This was cleaned, and once he was discharged, he was followed up by telepodiatry, and with good advice, rest, offloading, antibiotics, the wound healed. But this was another patient where an example where telepodiatry can be used for triage. So this patient presented on telepodiatry with a wound like this. We said you cannot manage on telepodiatry. He said he cannot visit the hospital. He went to another hospital, but the wound became bad. So finally, he went to a nearby hospital. The wound became bad. So eventually, he visited our hospital. You can see a sloughy, necrotic wound near the heel with pus coming out. He underwent debridement. A lot of pus was drained. And you can also see that some sort of suturing was done by a surgeon to keep the wound closed. Pus continued to drain, but then the wound started healing, and then we left it open for some time, and the wound began to granulate, and it did well. So here, this is a case where telepodiatry did not help in this patient's treatment, but it helped to convince the patient to come for care. So we told the patient, you have to come for care, and the patient came for care, and it was sorted out. So telepodiatry could be a useful triad system. So taking our experience, short experience actually, this is not a randomized trial, these are very small studies. So looking at our experience, we suggest these as a probable algorithm for telepodiatry. Fix an online appointment, an online communication with the patient, request the patient to share all medical records prior to the communication, obtain appropriate consent. If there is a diabetic foot problem and if it's a complicated case, sepsis, ulcer, necrotizing fasciitis, acute Charcot's, I think it's important to visit the hospital for further management. And then after initial care, you can do telepodiatry or telemedicine for follow-up. Now, if it is a diabetic foot problem like early cellulitis, minor injury, neuropathic problem, again, even these patients should visit the hospital. Remember, when you see a patient with a early cellulitis, a photograph cannot pick up the degree of the redness or the spread of the cellulitis. If you see a patient with a minor injury, a photograph on telepodiatry cannot tell you the depth of the injury, whether you can see pus, whether it's probing to bone, whether tendons can be seen, it cannot be noted. Also, when you have a neuropathic patient and you have a neuropathic patient with a neuropathic symptoms, you don't know if there is a callus under the great toe. You don't know if that callus is going to break down. You do not know if it's a Charcot's foot developing. So all these things can be very difficult to diagnose by teleconsultation. And even these patients ideally should visit the hospital. Now, if the hospital visit is possible, visit and manage at the hospital. But not possible, you'll have to manage by telemedicine. So friends, I've discussed uh, three cases with three messages. I think the pandemic, as Dr. Kanungo rightly mentioned, has uh, been distressing for patients who could not visit the hospital. Even today, the pandemic continues to rage, and a lot of doctors are doing telemedicine and teleconsultations. I think that there is the promise of remote care for hyperglycemia management and gestational diabetes, where pregnant women do not want to be exposed to viral infections. And there is also remote use of technology, both self-monitored blood glucose and CGM. This has been facilitated by glucometers, which link to mobile phones via Bluetooth, and also which are connected to web, and the doctor or diabetes educator sitting in the comfort of their clinic can actually make decisions with the patient. Now, telepodiatry, I talked about this published series where telepodiatry was a form of triage. Telepodiatry should be used very carefully because, as I said, telepodiatry cannot be used for routine care. But yes, in selected cases, you might like to use it. And telepodiatry may have help you as a form of triage, where moderate and high risk patients could be brought to hospital. But low risk patients with minor illnesses, you might be able to manage and advise. I think the pandemic has again augmented the sheer burden of diabetes with ground realities. Having internet connections, a good infrastructure is needed. But wherever possible, I prefer my patients to visit the hospital rather than telepodiatry. Thank you so much for listening to me, friends. Once again, Dr. Kanungu and team, it has been a pleasure being here. Thank you so much.